Hello, good evening. Has anyone joined? Hello? Has anyone joined? Hello? 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 Hello, Monali? Hello, Mamta?
Good evening, ma'am.
Good evening. How are you?
I'm fine, ma'am. Thank you, ma'am. How are you?
All good. Is this Mamta's voice or Monali's voice?
Ma'am Monali.
Okay, Monali. Where do you practice, Monali?
Ma'am, I'm currently working as an assistant professor at Mata Gujri University, Kishanganj, in Bihar.
Oh, okay. All right. Lot of challenges, I'm sure.
Definitely, ma'am. The major one being illiteracy and poverty.
Yeah. Yeah. Kishanganj, I mean, I hope you have some instruments with you.
We do have, it's not like we don't have, but they are quite outdated. Those things that we used to use in maybe 2000, we're currently using the same instruments.
Oh, I really appreciate people who are working in the rural areas and peripheral. I mean, like one tier city. It's very hard.
Yes, ma'am.
So I'm sure you're getting all kinds of emergencies and all. And I,
Everything. We do have a variety of cases. We don't have any problem with that.
and also advanced, right? Like people present late, right? Because of low literacy.
Yes, ma'am.
Yeah. You should share clinical pictures now and then.
Sure, ma'am. Definitely.
Yeah, Monali. So anybody with you in the department?
Yes, ma'am. We have, I think Dr. Paramita is there. She is our professor.
Good evening, ma'am.
Okay. Yeah, Manvi. Hi.
I actually there is some issue with Ashima's credentials. I'm not able to log in through that. So I'll just check, Dr. Sindhuja, if you can just check if you are there. I don't know. I think she's not there. Dr. Stuti is calling me.
And
Yeah, Dr. Stuti is also calling me, ma'am.
yeah, I think I'm unable to join. There's some
Yeah, yeah.
yeah.
I'm just एक second, ma'am.
Hello, ma'am.
Yeah,
Hello.
Dr.
Ma'am, I'm audible?
Yes,
Yeah,
yes,
yeah.
very well.
Okay,
I don't
ma'am.
know.
Okay, ma'am.
Yeah, Dr. Sindhuja, if you can just try and share by using that share button.
Okay, ma'am. Okay.
Also share your video.
Okay, ma'am.
So Manvi, why don't you speak to Stuti? That's an issue.
Yes, ma'am. Yes, ma'am. I'll just talk to her.
Hello, Mamta. Hello, Paromita.
Hello, ma'am. How are you?
I'm good, Paromita. How are you?
I'm also fine, ma'am.
Nice having you online.
Thank you, ma'am.
I
It is
think,
such an interesting topic.
yeah,
Such
interesting.
an
She specialized in pediatric ENT, Stuti.
okay, ma'am.
Yeah, she did it from CMC Vellore, so it'll be interesting to hear. I'm so happy for all WA members who are doing newer stuff these days. Who else wants to say hello?
Ma'am, my screen shared or not, ma'am?
1 minute. Yes, Sindhuja. I can see the
Yes.
screen now. No problem. But we can't see your face.
Ma'am, I have no webcam, ma'am, at present. It's not working.
Oh, okay, okay. No problem. But the screen I can see.
Okay, ma'am.
Okay, good. Who else is online? Hi, Rupali.
Oh, hi.
Lovely having you after a long time.
One second.
Your lecture is due, Rupali.
Yes, yes, yes. We will surely take anytime. How are you?
All good, Rupali. I think the speaker is unable to join. We'll have to give her 5 minutes.
Dr. Stuti is here. I've asked her to
Oh,
check.
wonderful.
Yeah.
Welcome, Stuti. Stuti, are you able to join? I mean, you've joined, but are you able to share the screen?
Ma'am, it's telling me like somebody else is sharing, so I cannot share.
Okay.
How stop my sharing, ma'am?
There's some background noise. All of you mute your devices, please. Hello, Athira. Good to have you. Hello, Sanskriti. Hello, Arshi. Manvi.
Yes,
Hello.
ma'am. Yes, ma'am.
Can we
Oh,
start, Manvi?
yes, ma'am. Dr. Stuti, are you able to play your Zoom?
Yeah, I'm able
Yeah.
to play. Is my screen
Yeah,
visible
I
to
can see
everyone?
the
Yeah,
screen.
yeah, the screen is visible. And if there are any videos, you can just try playing them also once because we still have a minute.
I don't have any videos currently for
Okay,
this one.
that's fine. That's fine.
No
Yeah.
problem. So let
No.
me start the session. Good evening, dear all. Good evening, WI members, friends. It's lovely to meet up like this regularly, online at least. Offline, we're able to conduct a few conferences, but they're not so regular. Hopefully, we'll have more in future. But these learning sessions really stimulate each and everyone. There's so much to learn. We're all learning, and there are some brilliant young minds. Like today, we have another brilliant mind, Dr. Stuti Chowdhary, who would be speaking on drooling in children. She specialized in pediatric ENT. She's currently working as assistant professor in ENT at AIIMS Nagpur. She completed her MBBS from MGIMS Sevagram, then MSENT from JIPMA Pondicherry. That's good, from JIPMA. And then DNB ENT in 2022 and senior residency and fellowship and pediatric ENT from CMC Vellore. That's another good institution. So, welcome, dear Stuti. Her special interest is basically in pediatric ENT, including malformations, hearing loss, cochlear implants, and pediatric airway. She's a Bengali married to a Maharashtrian, and that's her based in Nagpur for the last 7 years. Oh, no, she spent 7 years in south of India. Yeah, that we can see. You've spent a lot of time in Tamil Nadu. So I think you've learned the language too. So welcome, dear Stuti. We're looking forward to your lecture. Over to you.
Thank you, ma'am, for this kind introduction. Good evening to one and all. I'd like to thank WAOI for this wonderful opportunity. I apologize if I don't know many people here on the platform, as I'm quite new here, but I'd like to contribute meaningfully to this platform from now on. So I hope I'm audible and my screen is visible to everybody.
Yes.
Yeah, sure. So then we can proceed. So today the topic of our discussion here is drooling in children. So why do we need this topic at all? So I'm sure all of us have come across children who drool, neurologically impaired children, and very rarely do we actually go ahead and treat such children. We think that it is a part and parcel of the underlying condition that they have. While it is not so, specialized care towards drooling in children is required to avoid a lot of problems that we will see today.
So we'll start with a clinical case for the benefit of the residents here. So a 6-year-old girl came to the pediatric ENT OPD with complaints of drooling of saliva from the mouth since infancy. It was also associated with difficulty in swallowing solids and liquids. She had unclear speech and had constant dribbling of saliva from the mouth. Examination showed drooling of saliva with perioral excoriations and poor motor control of swallow. Lip closure and bolus formation was found to be inadequate. So, based on this ultra short clinical case scenario, what are the red flags that we see here? The first red flag will be the age. 6-year-old girl drooling is not okay. The second is it is also associated with difficulty. It has progressed to dysphagia. It has not been limited to simple drooling. And there's been speech and other problems as well. There's examination wise, it is drooling, it is causing excoriations, and there is poor motor control as well. So this child has had drooling plus its sequelae as well at the age of 6. So we proceed to how we work up this case. So today, what is in store for all of us? So there's the definition, the presentation, the diagnosis, management, and what are the current updates in the world of drooling for children. So drooling or salivary incontinence is an indication of an upset in the coordinated control mechanism of orofacial and palatal-lingual musculature, basically the voluntary motor musculature involved in swallowing, leading to excessive drooling of saliva in the anterior mouth and resulting in unintentional loss of saliva from the mouth. So this is a comprehensive definition, but what we need to see here is that there is also something called posterior drooling. When the anterior collection overflows to the back of the throat, that is also a part of our drooling spectrum. So it is normal in healthy infants, especially when they are beginning teething and all, but it should stop by 18 months of age. It is abnormal if it persists beyond the age of 4 years. So what do we understand by drooling individually? Is it the same as sialorrhea? So if you look at it, it is the same difference as lacrimation versus epiphora. So drooling and sialorrhea, of which drooling is a passive thing and sialorrhea is an active oversecretion. And drooling is a passive inability to drain that oversecretion. Then can we call drooling as salivary incontinence? Yes, we can. And there's anterior versus posterior that we will look at in a few further slides. Other old archaic terms that we have used was sialism or tialism, which are not used nowadays. So, of course, drooling is different from hypersalivation, where there is excess generation of saliva at the source, that is at the salivary gland level. And they cause a lot of problems with drooling. Like if you can see in the picture, the first picture shows a child with extensive perioral excoriations, and the excoriations have spread to the neck, to the cheek. Habitual rubbing, habitual bib usage is responsible for such kind of rashes. Then it is also a functional, social, psychological problem. There are clinical consequences as well. When the saliva is overflowing, it leads to dental enamel erosion. There's perioral infections, and there are pulmonary complications as well in posterior drooling. So now, what should we do for this drooling? Is it a problem? So a quick look at the neural control and the pathophysiology. So there are afferents and efferents for salivary production. There are chemoreceptors, mechanoreceptors, which contribute to the salivary production. And of course, it responds to olfactory cues as well. And based on our stomach contents, our saliva production also varies. The salivary nuclei we know are in medulla oblongata. The efferent is always parasympathetic. The important thing to note here is the submandibular gland contributes maximally to the resting salivary saliva production. The parotid and all come into action only when we are actively chewing. In children, we can estimate from 0.5 to 1.5 liter of total normal salivary production, which should be cleared by a normal child in 600 swallows over a period of 24 hours. So now causes we know it's mostly neurological, which are much more common than anatomic, which is again more common than active excess production at the gland level. So we all know that dental disease might contribute and is also a result of drooling. There is abnormal head position if the child is not able to maintain a correct posture required for passive swallowing as well, then that contributes to anterior drooling. Then there are sometimes loss of oral sensory awareness cues. Children are not able to understand when the saliva is too much to initiate a swallow in the first place. And there is lack of hypopharyngeal and laryngeal secretions, sensations, which do not detect the secretions which should be swallowed. In cerebral palsy, however, the incidence is as high as 10 to 38%. And children with constant drooling need a lot more attention and care from the caregiver side. So this is a table of the major causes of drooling that we have. Important to note here is a lot of causes are actually physiological in children. The commonest here we see are central nervous system disorders and gastroesophageal reflux. Similarly, in the second table, if we see cerebral palsy and hypoxic ischemic encephalopathy are the commonest causes of drooling seen in our clinical practice. In a busy pediatric ENT OPD, if there are 10 children with drooling, 8 children will either have a CP or HIE related sequelae. The others are very less in incidence, and we need to rule out other things which are the prosthodontist's domain, such as malocclusion, poor tongue thrust, constant open mouth, and poor lip control, which can be improved with prosthodontic care. Along with anesthesia, hyperesthesia of lips, and congenital acquired deformities of the tongue also need to be ruled out. The other syndromic associations are extremely rare, of which Sjogren's syndrome will initially lead to hypersalivation followed by dryness. So why is it a problem? So why can't we let drooling be? Why should we treat it? So social, of course, we know it soils clothing, it soils furniture, it soils common communicative devices in families, at public places, at parks. It soils toys, and it is a social nuisance. It is a problem with children growing up with a poor quality of life. It will cause perioral problems, of course, it is unesthetic. And we know that saliva is a buffer and a source of ions for remineralization of teeth. So the saliva is not staying long enough for the buffer action to work. It is simply flowing away. That causes demineralization and loss of enamel, and subsequent the downstream cascade of various tooth and dental problems later in life. So what tooth problems do we expect? Gingivitis we can expect. We can expect cheilitis, tooth destruction, excessive wiping leading to commissure, fissuring, and burning sensation of the mucous membrane when saliva is constantly in a flux. So how do we go about it? So the first point is obviously history, like in any other clinical problem. So we look at the severity, the effect it is having on the quality of life, and whether the child is on any therapeutic regimen, any drugs, any medications that are going on that can lead to increased salivary production, and whether there was any history of any antenatal polyhydramnios. Examination wise, we can see volumetric measurements for absolute quantification of the overspill of the saliva. There are multiple volumetric measurements that we will look at later. There are multiple external collection devices as well, such as the Carlsen Crittenden cups and the Eppendorf's tubes, which are used for collection and estimation. We can also estimate the amount of salivary flow by an intraoral suction, in which every 5 to 10 minutes, the amount of suction can be quantified and the entire salivary flow rate can be calculated as ml per minute. Physical findings such as skin maceration, ulcers on hands and mouth, especially if the drooling has spilled over to the anterior neck or the chest, can also lead to a diagnosis about how bad the drooling really is. And a head and neck general oral examination also is required, whether the child can swallow well, whether the child has adequate neck control, whether the child has proper orolabial closure, whether there is good oromuscular tone is what we need to examine. So these are certain other criteria that we can use. Most of them are archaic and not used at present. We've discussed quite a lot of it. The important thing that we have to know here is that nasal obstruction and appearance of tissues on anterior rhinoscopy. Is the child really obstructed from the nasal pathway? If it is so, then child will not be able to swallow, coordinate breathing and swallowing the saliva at the same time. So flexible nasopharyngoscopy should always be included in evaluation for swallowing. Swallowing efficiency, again determined more by observation. Barium swallow, I believe, is an overkill. Fiber optic endoscopy, again, is gold standard for an initial clinical examination. Neurological examination, of course, if the child is neurologically impaired, like we see commonly in our practice, radioscopy has become obsolete now. So now how do we calculate flow rates? So there are stimulated and unstimulated salivary flow rate calculations. For drooling children, an unstimulated calculation itself will be enough. It can be used the draining method or the dripping method, where we measure how much is passively overflowing, or whether we can dip a cotton in the saliva that is overflowing, a cotton pad which is pre-weighed and weighed again after thus it is wet with saliva fully. For this reason, we use something called the drooling quotient, which can be again DQ10 or DQ5, which is a validated semi-quantitative method. It is a directly observational method where the presence or absence or the degree of drooling is assessed in every 15-second periods during two different 10-minute periods separated by a 60-minute break and divided by 40 to express as a percentage. Important thing to note here is that this should be done at least 2 hours after a meal. So we know that this is an unstimulated salivary quotient that we are following. Again, swab method, cotton pad method, very crude but quite effective otherwise. In low resource settings, we can use these methods. They're graded as mild, moderate, or severe. And again, bib count again is a helpful clinical indicator. How many bibs is the child soaking throughout the day? So this shows a photograph of an Eppendorf's tubes. And as you can see in the second picture, this absorbent swab will collect all the saliva when placed in the floor of the mouth. And then it is preloaded inside a syringe, which compresses all the saliva into an Eppendorf's tube. This is a narrow tube, maximum capacity is 1.5 ml. And within 5 to 10 minutes, if this much is overflowing, we have a basic fair quantitative idea of how much is the drooling. So what are the scores that we have? So there are quite a lot, many validated scoring systems for quantifying drooling and for scoring when a drooling child should undergo surgical management or whether should undergo medical management. So the drool score, the drip score, the Comdel score are common, but the commonest used otherwise is the Thomas, Tonnell and Greenberg and the teacher's drooling scale. There are other severity and frequency scales and drooling outcome measures as well, which are mostly of academic interest. So this is the Thomas, Tonnell and Greenberg score. You can see that this gives a maximum score of 9, and it is quite subjective in nature, because the wet clothes, like you can see in severity, point number 4, wet clothes does not specify how wet and what cloth do they mean. Do they mean a bib? Do they mean a t-shirt? What do they mean? It is a little hazy, but nevertheless, it used to be a good gold standard criteria as a questionnaire. So now Christian Medical College Bangalore has developed this modified questionnaire, which includes a lot of problems that we as Indian practitioners will see in a drooling child, such as where does the drool fall? Where is the smell of the saliva offensive? And the social factor also is accounted. Do adults avoid your child due to drooling? The maximum score here is 44. This scoring has 11 points and it is fairly accurate. And according to this scoring, if it is more than 22 or 23, then we would like to intervene and manage. So this scoring questionnaire has been published. It is validated. It has been used widespread. Widespread use is there in south of India. So now, who needs treatment? So do we need to run and treat every child who comes to our OPD with drooling? So we need to see what is the impact on the quality of life, and it always has to be a trade-off between being totally dry and risking xerostomia. Should we go ahead with conservative treatment or surgery or a combination of both? And can the drooling be corrected with posture, oral care, or treating the nasal obstruction? And do we need to involve other clinical specialties such as an SLP, a speech and swallow therapist? Do we need to involve a neurologist? All this needs to be taken care of before we proceed to actually manage. So surgical treatment is best done when the child is more than or equal to 6 years of age. So we've given quite some time for the drooling to be confirmed that it is not going to improve. we definitely need to rule out aspiration and how the general growth and development of the child is. That includes a neurologist intervention. We have to rule out true hypersalivation as well, which means whether the glands are actively secreting more. It can be due to habitual finger chewing, or if there is any dental decay, any GERD, or any other drugs that the child is on. Posture, wheelchair use, and malocclusion needs to be treated along with the drooling. So, what is the role of the speech and swallow therapist? They can provide some oromotor therapy, they can provide oromotor training for muscle tone and to stabilize the posture while feeding. So, there are quite a lot of things that the SLPs usually suggest to increase lip closure and decrease tongue thrust. Basically, the tongue internal musculature, the intrinsic muscles of the tongue need to be hypertonic in order to hold the saliva in and swallow it as a bolus. For this, there are multiple oromotor exercises such as blowing bubbles or making the child try to suck up thin liquids through a straw. This kind of oromotor training slowly and surely improves the oromotor tone. There are multiple dental and prosthodontic appliances like improvised for the same. And there is something called kinesio taping, where they tape the tape. There's a special kind of tape available for the buccal sphincter, which is used to try to keep it closed. But it is not. It is a forceful method and not applied everywhere. So, like we said, a child practicing bubbles, or a child practicing drinking with a straw, or a child being encouraged to blow into a trumpet will actually help the child develop a little more of the buccal closure. Then these all are graduated exercises, and they include behavioral modification along with positive and negative reinforcements for the child to actually respond. Then we need fluoride supplementation in toothpastes. And if there is dental malocclusion, then we have something called the ISMAR device, which is the Innsbruck Sensory Motor Activation and Regulation Device. It gives a better motor control of the lower jaw, the hyoid, the tongue, and the palate. And in certain countries, but not in India, there is something called supercol. It is a feed thickener that is used to avoid the feeds getting aspirated because of the excess saliva. It's not yet available in India, but we have certain substitutes here as well. So that ends the role of the SLP. So what does the surgeon do now? So this is a photo of the ISMAR device that I spoke to you about. I'll speak about this device in detail later. So there is something that we as surgeons can do, that is pharmacotherapy. Anticholinergics, of course, glycopyrrolate is one, but the side effect profile is significant, especially if a neurologically impaired child is also on certain other drugs which can have drug interactions. Iosine, glycopyrrolate, all these can be used as transdermal patches, but again, there is irregular drug delivery risk. The dose normally used is 0.1 mg per kg in 3 divided doses. Then an extreme method again is irradiation of the salivary glands. Again, it is of theoretical interest, not practiced. Then a major chunk of practice is now going into Botox into the glands, that is botulinum, Botox A, 4 international units per kg into the submandibular glands. So here we target the submandibular gland specifically. But again, it has to be ultrasound guided, and it has its own side effect profile, such as torticollis dysphagia and excessive salivary thickening, which is unintended as well. So now, when do we do surgery? So after trying out all this, 22 to 35% will actually end up in surgery after 6 months of conservative management. And again, we need to rule out aspiration first. And surgery for anterior drooling will not improve the posterior drooling at all. So submandibular duct rerouting is again much more preferred than gland excision completely. And surgery is not for children who are improving on conservative methods and will actually develop oromotor competence over time. So it needs a certain experience on the part of the SLP to actually decide this. Surgery itself has 80 to 88% success rate, but it also has considerable morbidity. Long-term success is high, but complications include ranular formation, sialadenitis, bleeding, and tongue swelling. So unfortunately, I do not have surgical videos, but I could gather some photos of this. So this is what we are doing is the submandibular gland duct rerouting. So we incise the floor of mouth mucosa with an island around the submandibular gland duct papillae. with that island intact, we tunnel out the entire duct, we dissect out the entire duct in its tunnel, and we create a loop, like we put a loop around the duct to keep it safe. Then we tunnel intramuscularly, another fresh tunnel we make, which ends at the level of the anterior tonsillar pillars, and the ducts are transposed there and sutured at the level of the pillars. So this is what we do. We are converting an anterior overflow of the saliva into a posterior passive flow. So for that, we again need to rule out that there is no aspiration at all already. So it is not a very challenging surgery, but again, it has its own pitfalls like any other surgery. So submandibular duct rerouting again has no external scar, but the biggest problem here is a ranula and duct obstruction, which can happen after the surgery and might need additional surgery for persistent drooling if submandibular gland duct rerouting alone does not work. Then again, parotid duct rerouting is also there, gland excision is also there, and transtympanic neurectomy is generally of theoretical interest and does not contribute much to the salivary flow. So what if child turns out to have chronic aspiration as well? So you were focusing more on the anterior drooling, and child has posterior drooling as well. So what do? We need to suspect certain structural causes. Is the child's mandible well formed? Does the child look like he has retrognathia? Does the child look like he has a posteriorly based bulky tongue that is hampering his oral closure? Does he have any kind of tracheoesophageal fistulas, which is leading to excess salivation, aspiration, multiple pneumonias, lung problems? Is the child on tube feeding? Is he on a nasogastric tube? And does postural exercise or feed thickening improve his condition or not? Is the child requiring multiple swallows to swallow a simple liquid bolus? All these, if they are yes, if answers are yes, then we go ahead for a gastrostomy or a fundoplication along with your drooling surgery. These are again very extreme steps and usually is not required in many children. So this is the standard textbook flowchart that we have for aspiration. I'm sure everybody is familiar. We need to rule out clinical aspiration. We modify the diet, thickeners for fluids, postural advice, and we always need to treat reflux. And if we cannot do that, we manage surgically. We consider anticholinergics, we consider Botox, we consider gland excision or rerouting. And ultimately, we do narrowfield laryngotracheal separation, narrowfield laryngectomy or laryngotracheal separation. So this is a short flow chart that shows how we go about managing a child with drooling. If it is a treatable prosthodontic problem, then please go ahead and refer the child to your dental colleagues. And if there is failure of resolution, I recommend a period of 6 months after the child has turned 4 years or more. We need a structured oromotor program, plus or minus an intraoral device, plus or minus medical options. After exhausting all of this, we go ahead to surgery. An intraoral device technically is quite uncomfortable, and personally, I've seen children not doing so well with intraoral devices. And in a child who's already having a lot of other problems due to HIV or cerebral palsy or any other thing, an intraoral device is not kind to be used on children. This is the update that I was talking about, this device that we saw. So it has a rolling ball at the posterior end of this wired device that sticks to the hard palate superiorly. This ball, the child tends to touch the tongue to this ball, which helps in subconscious increasing in the tone of the tongue while the child is balancing this ball in the center. So this helps in tongue musculature strengthening, which helps in initiating the oral phase of swallow. So there are a lot of updates going on in the drooling world in pediatric ENT. There is salivary gland duct photocoagulation, and there is tongue acupuncture being used without much success. Then people are experimenting with multiple variants of Botox. And again, there are different palatolabial lingual devices and biofeedback as a therapy measure to improve the tone. So the take-home message today is it's a wide spectrum. Every child with drooling has a different scenario, a different challenge with feed, with aspiration, with dental issues, with caregiver problems, and each case need to be seen on an individual basis. But drooling is very, very treatable. It is very it has a bad effect on the quality of life. So every effort should be made to treat it. And age of the child definitely should be kept in mind. A multidisciplinary team involvement is essential. It will let us treat the child holistically. And surgery and Botox, although popular, have their own pitfalls and should be taken up after MDT discussion with great care. Thank you for being patient listeners. I'll be okay to take some questions now. Thank you.
Thank you, Stuti. That was an excellent lecture, nice and concise. And you've stimulated everybody to actually take up more such cases. You've
Thank you,
also
ma'am.
spoken about, rerouting of the ducts. So, what is your statistics like? How many surgical procedures have you guys performed? Parachute
So,
ducting.
ma'am, parotid I have not done.
Okay.
To be parotid, usually salivary, submandibular salivary gland duct ligation responded very well. Maybe on a statistic basis, if you see 20 children coming to our OPD over a period of 6 to 8 months, maybe 2 of them will proceed to surgery. And most of them will end up doing really well. And but the dental demineralization and all takes time to stabilize. But the aesthetic part, the excoriations part, the aspiration part tends to improve. So
Got it.
it's not a very widespread problem, but it is a very treatable one once we encounter it.
Right, right. Leena has a question, Dr. Leena Jain.
Yeah, sure, ma'am.
Can you see the chat box?
Sivamylene, no, ma'am. In children, there is not much evidence for sivamylene use. In adults, definitely. But again, it is a trade-off between how much xerostomia can the child take. They already do not have a lot of tone for the children who actually end up with drooling. And if we give too much of xerostomia, they'll end up gagging and choking and not being able to make the bolus at all. So again, on a trial basis can be used, ma'am, but personally I have not used. I have used a lot of glycopyrrolate and children respond well, and many of them slow down towards surgery with glycopyrrolate.
Okay, dear. Now I think we can proceed to the quiz. Thank you for your time. It was
Thank
a
you, ma'am.
wonderful
Thank you,
lecture.
ma'am.
God bless you, Stuti.
Thank
Thank
you,
you.
ma'am. Thank you.
Thank you. Now over to Sindhuja. Sindhuja, are you ready?
Yes, ma'am.
Okay, Dr. Sindhuja and Dr. Manvi Mehta, both of you are ready now?
Yes, ma'am.
Okay, let me
Yes.
introduce Dr. Sindhuja. She's assistant professor in Madurai Medical College. Welcome. Nice to see you from, the other part of India, far off from south.
Thank you, ma'am.
And how many postgraduates do you have under you?
Ma'am, we have 8 postgraduate in each year, ma'am.
Oh,
So
nice. So every
totally of
year, so
24.
24. Okay, 24.
Yes, ma'am.
A great number. Nice. I've
Yes, ma'am.
once seen, it's in Rajaji Hospital, right?
Yes, ma'am.
Yeah, I've seen those OPD, you've got those sublets, 4 or 5 PGs were
Ma'am.
examining. I saw that. Yeah.
Yes, ma'am. Yes, ma'am.
So Dr. Sindhuja has done her MSc. She's assistant professor right now in Madurai Medical College. She's done a junior residency for 5 years in Shivagangai Medical College. And then she was a junior resident in Dindigal Medical College. And now, of course, in Madurai Medical College. And she did her MSc in 2019. Like she finished in 2022. So very young. And DLO from Madurai Medical College and MBBS was from Trichy. So lovely to have you, Sindhuja, on this platform. So all of you know how many participants, please? How many PGs do we have on this platform? Manvi, do you want to find out how many are there?
Yes, ma'am. There are 33 participants, 28 participants right now. Those who are PGs can just raise your hands that we can have you in the. Anyone can participate, but it would be good, for the PGs because they'll be like brushed up with the knowledge and everything right now.
Yes, please. PGs, can you message in the chat box? Raise your hand. Okay, somebody has put a thumbs up.
Mhm. Okay, Dr. Sanskriti Jas.
Yeah.
Yes.
Yes.
Dr. Malika Sethi.
Okay.
Right.
Two
So two.
PGs anymore? Yeah, Pragya, Zaira. No, Zara.
Zara Batul. Right.
Good. There are 4 PGs. Wonderful. Any more? Any more? Okay. So we begin. First, Manvi, we will have scoring just for these 4. I hope,
Right.
it's
Right, ma'am.
individual, no grouping. All 4 will participate.
Right. And you just message your answers directly to me privately on the chat and we'll calculate your answers. Don't put it on the everyone chat, right? Just put it privately. The question number and answers, we have 20 questions, right?
Everyone has
Yes,
to
ma'am.
message. There's another one. There are 5 Manvi Shiv Mathur also.
Right,
Shivi
right.
Mathur. Yeah.
You can post on the chat here if you can see the message privately option. If you are not able to see, it's okay. You can message on my number with the question number. That's okay. We'll do it after everyone posts it. Okay. So no
One,
issues. If
yeah,
you
one,
see it on the group, it's on the Zoom, it's fine, or else just WhatsApp.
correct. So I hope everyone is ready. I hope it's clear. All the residents who are participating, good luck. And please privately message to Dr. Manvi Mehta. I hope all of you have the number.
I have put it on the chat also.
Ma'am, shall I share my screen?
1 second. Give me one more because Pragya is asking a question. It's on the number, Pragya, not chat here. I hope it's clear now. Yes, Sindhuja, you can start now.
Ma'am, my screen is
Yeah, we can see your
visible to
screen.
all.
Yes, my
Yes,
dear.
ma'am. Okay, ma'am. This quiz contains totally 20 questions. I give 1 mark for each question. And the PPT, each slide has 2 questions. So you can take time for 1.5 to 2 minutes for the each slide. Okay. I start the questions. Your time starts.
Please read out the
And
question.
you can read
Okay,
the
ma'am.
question, Dr.
The
Sindhuja.
question 1, Insights classification of parts tensa, which is grade 3. The option 1 is a retracted drum touching the promontory. Option 2 is retracted into the incus. The slide retraction of the pars tensa is option 3. The fourth option is drum is adherent to the promontory. This is the first question.
Okay, proceed.
I move on to the next question. Please identify the incision. The first option is McPhee incision. The second one is Schobinger. The third one is utility. The fourth one is lateral utility.
Okay.
The third question in TNM classification of regional lymph node for N2A is option 1 is metastasis into a single ipsilateral lymph node up to 3 centimeter or less in greatest dimension. The second option is it is metastasis in a single ipsilateral lymph node more than 3 centimeter but not more than 6 centimeter in its greatest dimension. The third is metastasis in a lymph node more than 6 centimeter in greatest dimension. The fourth one is the contralateral lymph node more than 6 centimeter in greatest dimension. Shall I move on to next question?
Yeah.
The question 4 is, which frequency are mostly affected initially in autosclerosis? It is option 1 is low frequency, 2 is mid frequency, and the third option is high frequency, fourth is none of the above.
Okay.
Question number 5. What is Donaldson line? What is its important? First one is this line extending the plane of the lateral semicircular canal and bisect the posterior canal into two. It's used for the surgical landmark for endolymphatic sac surgery. The second one is the plane of posterior semicircular canal bisect the superior semicircular canal. It is a surgical landmark for endolymphatic sac surgery. The third is the plane is a lateral semicircular canal bisect the posterior semicircular canal and surgical landmark for translabyrinthine surgery. Extending the plane of posterior semicircular canal, it bisects the lateral semicircular canal. This is a surgical landmark for the translabyrinthine approach.
Okay.
The question 6. What is the gold standard investigations for superior semicircular canal dehiscence? So option 1 is BERA and ABR. Option 2 is MRI with technetium-99 scan. And option 3 is MRI with gadolinium scan. Option 4 is HRCT.
Okay.
So question 7, so regarding the Merry index. So in Merry index, which is true? Merry index 0, the option 1 is Merry index 0, it is a severe disease. Merry index 4 to 6, it is a moderate disease. Option 3, Merry 1 to 3 is a normal. Merry 7 to 12 is a mild disease.
Okay.
The question 8 is oculomotor nerve and the relation with the cavernous sinus. The nerve situated in a lateral and roof of the cavernous sinus. The roof of wall of cavernous sinus. The option 2 is it is in medial and roof of wall of the cavernous sinus. And option 3, it is in medial and inferior inside the cavernous sinus. And the 4 is it is a lateral and inferior to wall of the cavernous sinus.
Okay.
So question number 9. It is a picture shows the endoscopic view of a transsphenoidal. So in this picture, you identify the medial and lateral optico-carotid recesses. The option 1 is 1 to 2. The option 2 is 2 and 3. The option 3 is 3 and 4. Option 5 is 5 and 4.
Okay.
The question 10. What is the protocol for ward decannulation in pediatric tracheostomy? Is Cotton-Meyer classification, Great Ormond Street protocol, Benton criteria. The fourth option is none of the above. The option 1 is Cotton-Meyer classification. Option 2 is Greater Ormond Street protocol. 3 is Benton criteria. 4 is none of the above.
Okay.
The question 11. Currently available treatment option for interventional delivery for perinatal airway management. So perinatal airway management. The option 1 is OOPS. Option 2 is exit. Option 3 is delivery of the baby, then attempted airway intubation or tracheostomy. Option 4 is all of the above.
Okay.
Question 12. Regarding SIGN, that is Scottish Intercollegiate Guidelines Network for tonsillectomy, all are true except. So this guidelines is based on the Paradise criteria, that is option 1. The 2 is it is for children and also adult. Option 3, there are 4 criteria. Option 4, for tonsillectomy, the patient should meet all the criteria.
Okay.
So question number 13, it's about internal nasal valve. The internal nasal valve formed by except. Option 1, the medial wall, so formed by septum. Option 2, lateral wall by caudal end of upper lateral cartilage, anterior part of inferior turbinate and the bony aperture. Option 3, nasal floor is by the floor of bony aperture. 4th is the roof by the nasal sill.
Okay.
Regarding the parapharyngeal space, which is false. Option 1 is it is inverted pyramid in shape. Option 2, the most common tumor in this space is benign. Option 3, the approaches through the parapharyngeal space is transcervical and transparotid. Option 4 is its apex lies inferiorly at upper border of thyroid cartilage. which is false. The question is which is false. Regarding the parapharyngeal space, which option is false?
Okay.
So it is an endoscopic picture. Identify the lesion. The option was Rinke's edema. Option 2 is bilateral vocal cord polyp. Option 3 is vocal cord growth. Option 4 is posterior postcricoid growth.
Okay.
The question number 16 is the following criteria are related to the AFRS except one. The following criteria are related to AFRS except. Option 1 is Benton-Hund criteria. Option 2, St. Paul's Sinus Center diagnostic criteria. Option 3, Kupferberg postoperative endoscopic staging. Option 4 is ARIA classification.
Okay.
So question 17, identify the condition in the CT of paranasal sinus. The option 1 is antracoinal polyp. Option 2 is chronic rhinosinusitis. Option 3, mucosilla concabulosa. Option 4 is ethmoidal polyp.
Okay.
Question number 18. So identify the condition. Option with subperiosteal abscess. Option 2 is orbital cellulitis with intraperiosteal abscess. Option 3 is cavernous sinus thrombosis. Option 4 is orbital cellulitis.
Okay.
So 19th question. A child with sensorineural hearing loss and the family history of sudden death is found to have a prolonged QT interval. What is the probable diagnosis? The option 1 is Schroeder's syndrome. Option 2 is Pendred syndrome. Option 3 is Jervell and Lange-Nielsen syndrome. Option 4 is Waardenburg syndrome.
Okay.
The last question, so 20th question. Identify the instrument. The first option is Carrison Coston instrument. Option 2 is Johnson Bone Nibbler. Option 3 is calcium forceps. Option 4 is ash forceps.
Okay.
Okay, ma'am.
Yeah, well done, Sindhuja. Excellent.
Thank you, ma'am.
You're going to be a great examiner in future, and I'm sure you're going to be invited from all over India.
Thank you, ma'am. Thank you, ma'am.
God bless.
Shall I stop the sharing, ma'am?
Yeah, you can stop, and now Dr. Manvi Mehta will do the scoring and let us know.
Okay, ma'am. Okay, ma'am.
Yeah, just give me 2 minutes. I'll just tell you the scores. I'm just calculating. So there are
Sure.
5 candidates. So I'm just calculating.
Yeah, yeah. Sindhuja, tell us more about yourself. How big is your family?
Ma'am, now I am in Madurai, ma'am.
Yeah.
My husband also a doctor. He's a internal medicine, and
Okay.
he also in Madurai Medical College as assistant professor of internal medicine department.
Nice. You did.
We both are, yeah, ma'am. We both are in Madurai Medical College. Previously, we both are in Sivagangai Medical College for near 7 years, ma'am. 5 to 6 years.
Okay, nice. So is that your
After,
daughter in the DP?
ma'am?
Is that your daughter in the DP?
Yes, ma'am. Yes, yes, ma'am. She is my
Ah,
daughter.
sweet. I think she's very young, 6-year-old.
The picture is at 6 year old, ma'am. Now she is 13 years.
Okay, nice. God bless.
She removed my photo and uh, um, upload her photo, ma'am, in the
Oh,
DP.
okay. Dr. Leena is an examiner here. Who else in the group are examiners here?
Ma'am, are you asking me, ma'am?
Yeah, no, Sindhuja, I'm asking others. You are a
Okay, ma'am.
professor in Madurai Medical College. I wanted to know how many here in the platform today are professors or associate professors. I want you all to know each other so that you can call each other. There should be rotation of these examiners instead of having the same examiner over and again. Are you still there, Leena? You can unmute yourself, Leena.
Yes, ma'am, here only.
So, are we having any
Hello.
examiners in this group?
Ah,
Suma
Teacher Suma.
Radhakrishnan. Okay, Suma Radhakrishnan, which college are you in? Kozhikode, okay. GMC is what? Gandhi Medical College.
No, madam, Government Medical College.
Oh, Government Medical
Kerala,
College.
Kerala.
Oh,
Kozhikode, Kerala. Yeah.
oh, nice. Welcome, Suma. Nice to have you. So,
Welcome. Thank you, madam.
so you're professor there, right? So,
Yeah,
how
yeah,
many
yeah, yeah.
PGs do you have under you?
Pardon? How many pages?
Yeah.
We have six MS per year. So 18 will be at a
Eight.
time.
Okay, Sindhuja said 24. So you people have 18.
Yeah, yeah.
Yeah, lovely. If you should come over to the WI conference next time.
Yeah, definitely, madam. I wanted to come last time itself, but I could not due to
And
some personal issues. The next time, definite.
okay, do you want to participate in a
Yeah,
similar manner? Do you want to give a lecture or conduct?
yeah, yeah. I'll give it, madam.
Yeah, lovely to have you, Dr. Sum. Anyone else? Dr. Manvi, are you ready now?
Just last 1 second. I'm almost done.
No problem. Yeah, unfortunately, the attendance is less today, but we have 3 professors here. One, Leena Jain, she's in Bilwada, Rajasthan, and Suma in Kozhikode, Kerala, and Dr. Sindhuja from Madurai, Tamil Nadu.
So we have a winner, Dr. Pragya.
So, congratulations, Dr. Pragya. You can announce the score.
Yeah, she got 17 right
Wow.
out of 20.
10 out of 20 is very
Yeah.
good score. Wonderful.
Yeah.
Pragya will send you something. It'll be a surprise gift for you.
Congratulations, Dr. Pragya. You can unmute if you are there.
Pragya, unmute yourself.
Hello.
Yeah, Pragya. Introduce
Uh,
yourself.
Good evening, everyone. I'm from University College of Medical Sciences in Delhi under Dr. Nilima ma'am and Kavita Goyal ma'am. Nilima Gupta ma'am and Kavita Goyal ma'am. I'm
Wonderful.
in my third year right now.
Excellent, Pragya. Dr. Nilima Gupta is also an excellent professor. Congratulations, Pragya. Well done.
Thank you, ma'am.
Congratulations, Dr. Pragya.
Thank you so much, ma'am.
Who's the second one, Manvi? Are you there, Manvi?
Yes, ma'am. There is a tie on second. Dr.
Oh,
Malika, Dr. Shivi, and the third one, I'm just telling you the name
okay.
because
For that,
she,
let me ask a question.
Dr. Sanskriti Jaiswal. So all three of them got 13 correct.
Okay, so we'll ask one common question for them. The question that Dr. Sindhuja asked, Ben and Kuhn criteria. Who's Kuhn? Please tell me that. And second is St. Paul's criteria. Now, who is that? Who works in St. Paul's and where is it? Can anybody answer this question? Then you get a runner-up, second prize. Can anyone answer this question? All three candidates?
Just raise.
Are you writing to Manvi?
Uh,
In Ben and Kuhn criteria, who is Kuhn? What is his full name and where is he? Second one, the St. Paul's criteria. Who is the person involved and where is it? Manvi, let me know if someone answers.
Actually, it's Dr. Pragya only who's answering.
Oh,
You are out. You are out of this tiebreaker.
okay.
You cannot answer, Dr. Pragya.
Okay, Shivi Mathur. Yes, Kuhn is Frederick Kuhn. Well done. And what about St. Paul's? St. Paul's, I'll give a hint. It's in Vancouver, Canada. Who's the person behind? No, none of you get the answer. So it's Amin Javed. Yeah, it is a sinus center. Both Dr. Frederick Kuhn and St. Paul Sinus Center. Yes, St. Paul Sinus Center is in Vancouver, run by Dr. Amin Javed. He has a lot of articles you can go through in OCNA and Rhinology, American Rhinology Clinics. Similarly, Dr. Frederick Kuhn, there are Kuhn's instruments, Kuhn criteria, and he's again a world famous sinus surgeon, retired now. Okay, we had a lovely evening. Thank you, Dr. Stuti. Thank you, Dr. Sindhuja. And thank you all for attending. Congratulations, Pragya, once again. Hope to see you all very soon. Thank you, Manvi.
Thank you, ma'am.
Thank
Thank
you,
you,
ma'am.
everyone.
Thank you all.
Thank you, ma'am.
Good night. Lovely
Thank
seeing
you,
you.
ma'am.
Okay, good night. I could just log in when everyone was
Oh, I
closing out.
Poland. Wow. We have celebrity now on the platform.
I just popped in to say bye.
Thank you, Ashima, for joining. You're a great inspiration for everyone. I'm sure they're going to follow you. Many want to be CI surgeons. You'll have to tell them your story.
Sure, any day, have to look.
Okay,
Okay, bye.
bye. Good night.